Good evening. I'm Jeffrey Coe. I'm an orthopedic spine surgeon in Northern California, and I am the co-chair of the Lumbar Spine Research Society Education Committee. I have the honor of hosting and moderating this webinar on the business aspects of spine surgery on ASCs and specialty hospitals. Since the COVID pandemic has begun, the Society has made a concerted effort to periodically, every 6 to 8 weeks or so, put on a webinar of interest to our members and also to the spine surgery committee or community in general. This is the third in the series. This agenda today is a recapitulation of a part of the instructional course that was wildly successful at our 2019 annual meeting. I'm honored to have as faculty Thomas Zadeblik, MD, who is the professor and chair of the Department of Orthopedic Surgery and Rehabilitation at the University of Wisconsin. Tom also is the founding member, if there is any single guy. It was his idea to form our Lumbar Spine Research Society when I was our first president. We're honored to have him. Dr. Greg Schroeder is an assistant professor of orthopedic spine surgery at the Rothman Institute at Thomas Jefferson University. He's done a lot of work on the finances of ambulatory surgery centers, and he'll have an excellent presentation. Dr. Michael Gerling is chief of spine surgery at NYU Langone facility in Brooklyn. He has tremendous experience in ambulatory spine surgery as well. And then I'm in private practice in Northern California, and I'll be giving a recapitulation on my most recent 10 years experience with ambulatory spine surgery. So without any further ado, Dr. Zadeblik will discuss his efforts on designing and building a specialty hospital. Tom?
Thank you, Jeff. And it's a pleasure to be here. I haven't been part of our own webinars yet, and I'm excited to have all of you with us online. I'm going to talk about my experience designing and building a surgical hospital at a major academic center. Slightly different than those of you that are in private practice, but I think there's lessons learned throughout this process, and I'll be happy to share them. Let's see. So I'm going to talk about the process of how we designed this, built it, what we learned, and how I would do it differently if I had to do it over again. This is an artist's drawing of the American Center at UW Hospital, and I'll go through how we got there. This is the major complex at University of Wisconsin Hospitals and Clinics, and it's a conglomeration of about 5 different buildings that includes the main hospital here, 2 research towers, pediatric hospital, a 3rd research tower, the VA hospital. And what wasn't working at a big, complex academic medical center? Well, what works well is that it is a busy level 1 trauma center. It's also the 3rd busiest transplant center in America. It's a large regional referral cancer center. We have every consultant or every imaginable specialty at the UW. And we had all of our faculty and residents on 1 campus in 1 place. So that part was working well. What doesn't work well at a large institution, particularly for orthopedics, is that our start times in the operating room were never quite where they should have been. We had long turnover times. As you can imagine, with level 1 trauma and transplants, we had constant emergencies that would crowd the elective schedule and push things off into the evening. And we weren't really focused on the patient and their family experience. We started about 8 years ago looking at the lean process. The lean process is how Toyota builds factories and then builds their cars. Virginia Mason Hospital in Seattle was the first hospital in America to adopt the lean process and re-engineered some of their processes and techniques. And I believe we're the first hospital that used the lean process from the ground up to design process, then building, and then built it. So what's the concepts involved with lean? It's really involved in having minimal wasted motion in the production of a valuable product. It eliminates anything that doesn't add value. It gives all of the employees and workers to stop the line at any point in time if they detect a problem. It uses a flow process to eliminate unevenness so that things arrive just in time when they're needed. It pulls all the services where they're needed. And in a hospital setting, that means you're pulling everything to the patient so the patient's not wandering around a building looking for where they have to go next. And also one of the lean concepts is that their managers are always on the factory floor. And so as a chair, I've always tried to keep operating and be on the operating room. Our hospital administrator is constantly on the factory floor at the hospital and seeing how things go. So we started 8 years ago by first evaluating every interaction we had with our patients, either in clinic or in the operating room, and we tried to reduce anything that wasn't of value. We then hired a qualified architect who is conversant in lean. We designed and modeled everything we needed to do, and then built mock-ups and then full-scale models, and then we build it. It's a fun process. The first step is this problem-solving fishbone diagram, where you look at a problem. For instance, why do we start so late in the operating room? And you keep asking why 5 different times until you start figuring out all the things you could change to make that better. So for instance, here in an appointment system, why people are always standing in front of the front desk? Well, you can ask yourself, is it the system itself, the bureaucracy, the informatics, the physicians themselves? Ask why at each way. And you start building these diagrams that ask that question so that you can then begin to answer them to streamline your process to arrive at an answer. So we did this at our hospital. We had probably over 100 people there, anesthesia, nursing, physicians, residents, administrators. And we started looking from every angle at how we handle patients in the clinic and in the operating room to reduce waste and inefficiency. We put it all down on a diagram and we started discussing it as a group. We started laying these panels out that looked at all the why questions and the potential answers and how we could use those answers to build a better building. We then started building blueprints of where things should go. And we actually had every single person, over 80 people, build their own blueprint on paper to start with. We then put these blueprints up on a wall in a shell space at the hospital. And we all started critiquing each other's blueprints, started asking questions, starting to say, I like this, I don't like that. We then broke up into 10 different teams, and each team got together to start building a more detailed blueprint on a more structured environment. From those blueprints, we then each team built scale models, not scale models, built small models of how the OR suite, for instance, would look, or how the clinics area would look. And we did that for both the pre and post-op area, the clinics, and the operating room suites to see how they would work most efficiently. And it's fascinating. Once you start building these small models, you can actually map out every step that a patient or a nurse, a physician, or a resident would have to take. For instance, here in this mock-up of a pre and post-op check-in area, we mapped out with yarn every step that everyone would have to take and started moving things around to minimize each of those steps for each patient and for all of our staff. It's amazing what you can start changing when you do that. We then had a very interactive couple of days where we examined each of these models, looked at the pros and cons, and started picking our favorite models for how we were going to build things. And actually the OR suites with 14 operating rooms was pretty much the design of one of our OR nurses who had been in the OR for about 12 years and had a great deal of experience. And it turned out to be her design that I ended up using. We then actually built full-scale mock-ups with cardboard and like for instance, here's an operating room we mocked up out of cardboard, exact dimensions. We had a OR table in there. We got to figure out where all the flat screens would go, where the clocks would go, where the speakers would go, how the doors would open, where everything would be on the ceiling to make things really efficient and really work well. This is the final design we came up with. On the left are the inpatient towers. There's 60 inpatient beds over here on the left. In the center is the clinic area. This is all clinic space here. This is the sports medicine with a football field, basketball court, and all of our sports performance areas. And then the operating suites are all on the first and second floor here. So then we built it. That was kind of fun. We got to watch it all go up. This is the final product. This is part of the sports performance area here on the right. It's got an exact replica of the UW Cole Center basketball court and a 40-yard replica of Camp Randall turf. It's got a beautiful entry for patients to see when they come in. And we've now been open almost 4 years. And I would say we kind of learned what's worked and what didn't work. So in the pre-post area, we set this up much like Disneyland does, where things are on stage and off stage. So the patients and their family only see this corridor where they come in, check into their room, and don't see anything else except that. And they never leave that room. If they're having a block or an epidural, it's done in that room. They're seen by anesthesia, by the residents, and surgery and anesthesia, all in that same room. until they're wheeled into the operating room, and they go back to the same room after the recovery room. This is how it looks from the other side. So this is the on-stage side where the residents, anesthesiologists, and the nurses are working, and they can enter each of those rooms through a separate corridor with 10 rooms per corridor. Very efficient way to work the pre and post-op area. In clinic, we set this up so that the patients stay in their clinic room. You hit a little scheduling button when you leave, and a scheduler comes into the room, looks at everything you've put on the computer, and sets up whether they need an MRI or a return clinic visit or a different test. That way we don't have the patient standing in line waiting for things to get scheduled after they're seen by a physician. This is sort of our clinic setup. This is on the second floor, which is all orthopedics. We have 5 corridors with 10 exam rooms in each of them. We have an x-ray suite area in the middle, and works very efficiently with all of the workstations here at the back where there's windows out over the woods and daylight. And then all the patients are coming in from this direction into their exam rooms and corridors. So this would be where the patients would be brought into their exam rooms in one corridor, and this is towards the back where our mid-levels and physicians are working in this area in the back. It's really nice to have 10 orthopedic surgeons in clinic at the same time. Every time you need a consult for a shoulder issue or a foot issue or a hip issue, you can just walk down the hall, see who's seeing patients that day, see if they can slide the patient you're seeing over into their clinic, and it makes it really efficient for patients that have made the trip. In the operating rooms, we made them really large so we could leave the robots and the microscopes all in their rooms. We built these prep rooms that straddle each of the 2 operating rooms that are sterile rooms that are in the central corridor, so that the nurses can be setting up all of your trays and instruments while you're closing one patient, so that as soon as that patient's out of the room, those sterile instruments and trays are brought in on their carts, and your turnover time is really reduced dramatically. We changed our ratio of of CRNAs to MDs so that there's 3 CRNAs to every anesthesiologist. We start right at 7 o'clock, 7:10 and 7:20. So the anesthesiologist is in each of those 3 rooms on time. Nobody's waiting. And then we have daylight coming into the corridors outside the operating rooms, which makes, I think, life a little nicer. So how is a surgical hospital like we built different than an ambulatory surgical center? Well, we do have inpatient beds. We have 60 inpatient beds that allow us to do larger spine cases and all of the joint replacements, including revisions. We have an EICU for a patient who may turn sour during surgery or have high blood loss. We do have hospitalists on site 24/7. We do most of our consults there by e-consults. We have all of our clinics in the same building. You know, if you're in an ambulatory surgical center, you often have to be somewhat nearby to a hospital in case you have to transfer somebody who's having trouble. You may have limits on the morbidities you can have for anesthesia. There's a potential in an ASC of pushing more people into the outpatient setting than may be appropriate. In many places, you have a nearby hotel, which really satisfies the outpatient need by basically having the first night recovering in a hotel with a nurse on board. So you'd have to set that up as well. So what didn't work well at the American Center? We never should have had an emergency room. I tried to lobby against it, but our administration really wanted one. It definitely makes it difficult to staff, and it's a little bit disruptive to a busy elective orthopedic schedule. We did set up urgent care for orthopedics only called OrthoCare now. And I would say that's been moderately successful. It's basically a walk-in clinic for minor orthopedic injuries. We had some challenges. It's not easy to have our faculty and residents now in 2 different locations, but I think we figured it out quite well with video conferencing and scheduling. It does disrupt the camaraderie a little bit. We did have to have an additional call schedule. We haven't quite filled all 60 inpatient beds, but as they brought more medical patients in, now we're starting to do that. And we do use mid-level coverage for things like urology consults and for rounding, which does make life much easier out there. What really worked well? We really built a strong team of anesthesiologists that only work at the American Center. So they have a very different way of thinking and acting than the anesthesiologists do at the larger hospital. They get efficiency. They get to go home when their case list is done. We start right on time at 7 o'clock. It's not completely orthopedics. We all have at least 1 OR a day that's general surgery. And that's worked out well in case you have some problem with bleeding or a larger complication where you might want an assistant to help you. This did require a culture change amongst our nursing staff, particularly for the start time and turnover. And we ended up hiring many nurses from outside of our system that were used to working at smaller private institutions that had similar type attitudes. I would highly recommend that you have hospitalists there if you're going to have inpatient beds. You do need an EICU in case you have someone who is sick, and a transport plan for someone who might have to go by ambulance back to the large hospital. So some things have changed here in the last 6 months since COVID. We were able to temporarily convert every one of our ORs to an ICU if needed. We had to reverse the airflow and make other changes. Luckily, they weren't needed, and we never had a COVID patient out at the American Center. That allowed us to reopen our operating rooms very quickly in May. We were basically back up to full schedule by mid-May. Very different from how University Hospital did it, where they're still not quite up to their full schedule. And I would say since COVID, we've also dramatically changed our need for all those exam rooms I showed you. I would say now approximately half of our visits are done by video. I don't need 5 exam rooms anymore to run my clinic. I can probably run it out of 2 exam rooms. So we're starting to convert some of our exam rooms into more private offices so we can have even more providers there at the same time, working on video and going back and forth between in-person visits and video visits. We've also switched much of our scheduling to virtual scheduling. So basically the patients get a phone call when they get home. That sets up everything they need scheduled. Would I do this again? Absolutely. You know, nobody likes change, especially as a surgeon, and my department was very reluctant when I first sprung this idea on them. But I would say that by engaging them in the design process, they really became part of their enthusiasm. And I would say nobody now would ever leave the American Center. Our volume went up 30%. Our satisfaction scores went up dramatically. Our surgeons are a lot happier actually working there. And I would say overall, it's been a great success. So I hope that you found some of this interesting, and thank you for your time.
All right, thank you, Dr. Zebdevlik. That's a wonderful presentation. We'll take the questions via the bar at the side and handle them at the end. Just type them into the window. Now we'll go on with Dr. Schroeder talking about finances of an ASC. Greg?
Thanks so much, Jeff. Great talk, Tom. So we're going to talk about the finances of an ASC. Here are my disclosures, none of which are relevant. Probably the closest thing to being relevant is that I do operate at a specialty hospital, but I do not have an ownership stake in it. All right, so I'm one of the spine surgeons at the Rothman Institute, and one of the big things that we do that I think whenever you're talking about the finances of an ambulatory surgery center, you really have to talk about is demand matching. So demand matching is basically a concept that we did not invent by any stretch of the imagination, but that we really push hard at, which is trying to do the right patient in the right facility. So if you are having a microdisc, you are not having a microdisc at Thomas Jefferson University Hospital unless there is some kind of major reason. You can either be at an ambulatory surgery center or a specialty hospital. But flip that around, if you are having a T10 to the pelvis, you're not having it at one of these other places. You need to be at a major university hospital. And then we kind of link the community hospital kind of as the person who probably is having a surgery that may be fine for one of the smaller hospitals, but maybe has a little bit more medical comorbidities. The criticism that you oftentimes hear about ambulatory surgery centers or specialty hospitals is really based off of our people cherry picking the cases. You know, and this was a study that was done that's quoted a lot that basically says, look, if you go to a full service hospital, these patients, about 13% of them are Medicaid compared to the specialty hospitals, which is 3.7%. You know, we tried to look at this and tried to kind of compare apples to apples, and we did a couple of studies a couple of years ago looking at this. So we compared patients who had 1 and 2 level ACDFs who were done either at the Rothman Specialty Hospital or an independent community hospital. And when we look at this, we found that there really was no difference in patient demographics. And really, there was no difference in any variable that we looked at for these patients. No difference in the number of patients who underwent physical therapy before having surgery, who underwent a cervical steroid injection. There was no difference in any of kind of the predictive factors for, you know, one of the criticisms of surgeon-owned facilities is always that, oh, maybe you're doing more inflating the numbers and not doing the non-operative care. But from the onset of symptoms to surgery was the same time. Really, everything was basically the same between the groups. Now, flip that, when we compared the patients who had surgery at the Rothman Specialty Hospital to patients who had surgery at Thomas Jefferson University Hospital, there was a dramatic difference. But I don't think this is cherry picking. This is really us thinking of, who is the appropriate patient for Thomas Jefferson versus who's the appropriate patient for whether it's an ambulatory surgery center or a small physician-owned facility. Now, when we look at this, the next thing that we look at was kind of, well, are we changing the way that we operate on people? And the answer was no. So the median length of time from the onset of symptoms was actually faster to surgery in the people at Thomas Jefferson University Hospital than at the specialty hospital. But the time from you saw the surgeon until you got to surgery was actually quicker if you were at the specialty hospital. So it's important to understand these kind of things when we're thinking about it, because the finances of the ambulatory surgery center or the specialty hospital are oftentimes linked to the criticism that we are cherry picking patients. But I think when you look at it, our data would suggest that we're not, other than that we're doing more complex cases at Thomas Jefferson and smaller cases at whether it's a physician-owned place or not, an ambulatory surgery center or a community hospital. One of the important things about the finances to understand is that the payments to the surgeons are really the same. And so realistically, the person who you are saving money now is usually the patients and the insurance companies. Now, so payments to the Rothman Specialty Hospital are only about 50% of what they are to Thomas Jefferson University Hospital if you're doing the exact same surgery. When we go to our kind of ambulatory surgery centers, they're even smaller. They're only about 40%. So this can have a real impact on these high deductible plans where patients are having to pay out of pocket. Also, it can have a impact on your ability to negotiate with the insurance company. So one of the things that we do at the Rothman Institute is try to work with the insurance companies and say, listen, don't lower our rates. We're going to do everything we can to take the appropriate patients out of kind of the high-end facilities. And so rather than cherry picking, we like to think of it as demand matching. But it's important to understand really realistically what is the media and what is the narrative that is out there. So as we're sitting here having a conversation about the finances of ambulatory surgery centers and the finances of physician-owned hospitals, there are, this was northjersey.com, people are dying after procedures in New Jersey surgical centers, and it's not always made public. USA Today a year or two had an entire article all about how push to cut costs and boost profits has led to a trail of death in surgery centers. And not surprising, if you go through here, these are a couple of patients who all had most likely anterior cervical discectomies and fusions that ended up dying after being in a surgical center. This was CBS this morning talking about the real dangers of the surgical center. So I do think it's important to understand that the optics are that you are doing this to move these patients out of the hospital to make you more money as a surgeon. I think as we kind of showed before, that you don't actually make more money doing the cases. The thought is that you have some small ownership stake that may lead you to want to push cases that direction. I think it's really important to understand the difference between a ambulatory surgery center like we have the Rothman Orthopedic Surgery Center at the Navy Yard, which has no beds, nothing available. Patients have to go home by 4 o'clock when the nursing staff leaves, or the Rothman Orthopedic Specialty Hospital, which for all intent and purposes is a glorified surgical center. We don't have any ICU, we don't have blood available, but we can have patients that can stay the night for even a couple of nights. So when we kind of transition into the costs of ambulatory surgery centers and how you can finance this and make it feasible for you, I think the biggest problem that most people have is that there's almost a complete lack of understanding of how much something costs. So oftentimes when you talk to, the hospital administrators, or when you read research papers, they oftentimes talk about, well, how much does it cost? Well, Medicare reimburses us, $100, so it costs $100. And that doesn't make any sense at all. That is a lot like saying that this Nike shoe that they are selling for $300 costs Nike $300 to make, even though it didn't cost them $300 to make at all, right? They have people working in sweatshops, maybe not, making these Nike shoes for cents on the dollar, and then they're turning around and selling them for $300. So what something costs has nothing to do with what you can sell it for or what you're being reimbursed for. So one of the big things that you have to do, and it's interesting in Tom's talk, because he was talking about the lead process and kind of walking through and drawing it out and seeing where people go to know how to build these centers. Well, from a cost standpoint, you realistically have to do the exact same thing. So there's an accounting method called time-driven activity-based costing, which is basically attempting to determine how much it actually costs to do something. So to create a cost unit for every step of the way. And so we did this previously for 1 and 2 level ACDFs at the Rothman Specialty Hospital. And we do have an ongoing project where we're looking at it for microdiscs and laminectomies, where we basically tracked every disposable cost, but we also tracked every time unit for how much time it's going into do an ACDF. And this included everything from, SPD that you don't see, to the surgeon's talk time, to the nursing time, to the therapy time. And it costs on average $30,000 to do an ACDF. And interesting, the largest cost was hospital disposable costs. And I think this has been really over and over again. So if we look at this, about 50% of our cost was hospital disposable costs. And this is probably the one thing that I think we're all pretty aware of as surgeons. Oh my gosh, sorry. And we have an ability to change. Things like hospital overhead and intraoperative personnel are a little bit harder to change. There are some things that you can do that we did kind of talk about, things like cell saver, like when are we using it, things along those lines to decrease the costs. And once we were able to do this, we really were able to significantly make some changes that allowed us to significantly decrease the cost. So first, we found that everybody was having a 10 cc flow seal opened every time. Oftentimes for a 1 level ACDF, at most you need a 5 cc flow seal, so we were able to change that. We had a couple of different bipolar options. One of our surgeons was using a bipolar that cost $1,000 every case, where there is actually a bipolar that comes free in our pack, or even a one that costs $100 that almost everybody else was using. There's also structural allograft versus a cage. There's not a lot of great data that suggests that a cage is a better choice, but it is a significantly more expensive choice. When you talk about how you're going to do this, one of the big things that we talk about is costing, or is the implant costs. So there's 2 major ways that you can handle implant costs. One is shelf costing, and one is a preferred vendor. Now, some of this is going to have a lot to do with how your ambulatory surgery center is set up. So if you are a small ambulatory surgery center that is not really connected to anything else, you're probably going to be better off doing the preferred vendor. The big problem with that is it limits you to 1 or 2 vendors, really limits what you can offer, but it can drive your price down. So the Rothman Specialty Hospital is a joint venture between the Rothman Institute as well as Thomas Jefferson University Hospital. So for us, we use shelf pricing that is basically matched across the entire Jefferson system, where we basically set a price and everybody has to come in, and any of the surgeons can use any pedicle screw they want, as long as the company is willing to meet our price. And there are significant issues in price. With this was another study from 2016 that showed that spinal implants cost for about half of the direct costs of a spine case. There have been studies talking about how just changing the way that surgeons even really think about it can dramatically drive down the cost. So this was a preferred vendor model and what they did, this was more for orthopedic trauma, but they identified a preferred vendor, mid-range, patient-specific requirements, and implants that were not available. And they basically gave this to everyone so that they knew and that they were supposed to try to use the green, and they ended up saving in the first year about $216,000 for their hospital. So there are ways that when you try to think about implants, you really can make a change. The last thing that I think that's important to talk about with the finances are really capital purchases. It's hard to discuss capital purchases on this talk for the simple fact that it can be very different depending on whether or not you are a small hospital or a portion of a large hospital. So for us at the Rothman Specialty Hospital, the capital budget is very similar to it is at Thomas Jefferson, where we put out things that we want and they tell us we have it or we don't have it in the budget. But one of the big things that we have tried to do that, particularly we talk about things like robots as they're gaining more prevalence in spine surgery, is determine the return of investment, not just for the hospital, but also for the implant manufacturer, and don't hesitate to use leverage on all parties, right? I mean, if you're a busy spine department, if you're going to talk about the price of a robot, if you're going to be using screws that maybe you weren't using before, there are ways that you can try to leverage that. Other things that you might be able to leverage to, if you need a new Metarex tube system, can you decrease your length of stay to get your hospital to pay for it? Those are the different things that I do think are really important. So in conclusion, I think when you talk about finances of ambulatory surgery center, I think demand matching has to be key. If you are bringing in patients who are not appropriate for either an ambulatory surgery center or a specialty hospital, and you're transferring patients out on a regular basis, you're going to lose a fortune. The second thing is that you really do have to know the cost of the surgery, and the only way to do this is to really be fastidious about it. And I mean, I think that time-driven activity-based costing is probably the best way to do it. And then lastly, be smart about your implants and capital expenditures. Thanks so much.
Great, Greg. Thank you so very much. We're running a little bit behind, but the content is very well worth it. Next, we'll have Mike Gerling discuss case selection and approach in the ambulatory setting. Mike?
The use of an ASC has been extremely helpful to me in my practice. It's been very efficient, and it's allowed me to really take my practice to a much higher level in terms of volume and productivity and being able to bring care to more patients. I do have some consulting disclosures that are not relevant. I have had ownership in ASCs in the past, but not for over a year and a half. So by definition, ambulatory surgery centers are places that do not offer emergency care or admission, even though they may let you have a 23-hour stay. The idea really is that patients are doing elective surgery that they will go home from or just have a very limited short-term supervision post-op. They initially started in 1970 with two surgeons in Phoenix who became very impatient with the with scheduling delays, limited operating room availability, other difficult inefficiencies that bothered them and made it very difficult to offer care. They had difficulty with control of equipment and other types of things, bureaucracies and whatnot that made them seek a better way to do things. And as things grew over the years, Medicare started accepting it, and in 1995, 2,000 procedures were actually accepted to be done in ASCs in the Medicare fee schedule. And things continued to grow with new types of providers and administrators being created and accepted within the field. And in 2011, really things started to flatten out a bit in America, but with more than 5,400 ASCs now, much more than that actually, but in that ballpark, that have been formed with 23 million surgeries were being performed back in 2011. I don't know what the current day statistic is, but it's quite a large volume, and that there are over 3,500 procedures that are actually approved by Medicare at this point to be performed in ASCs. So I mean, really, it's a huge volume. And why would a patient want that? I mean, there are advantages to both the patients and the surgeons, of course. Little things that we get complaints about sometimes, especially living in New York City, things like parking and transportation issues can sometimes be easier. In fact, a lot of private ASCs provide transportations for their patients in my environment. But just in general, they can have more convenience with pre-op testing and scheduling availability and just responsive care in the environment. Certainly, they perceive an increased efficiency in terms of pre-op testing, and the time of the encounters can be much easier in a more private, smaller setting where the experience can be more curated. And they also see cost savings as well. Their deductibles can be extremely high for surgeries and can be difficult for people to move forward. The facilities, as we know, and was already presented, can be much less expensive than hospitals. And if you look in the little chart on the right here, an ASC copay for a cataract surgery, for example, for the patient might be $193 versus $490 in a hospital outpatient department. And the procedure itself for the Medicare or for the payer could be $964 versus $1,670 in a hospital. So certainly there's a lot of cost savings, and it doesn't necessarily occur depending on certain facilities and if they're not in network. But for the most part, there is a cost saving for most patients that are undergoing ASC care. Certainly the other issue is how happy are they overall, and studies have been done on it showing that even though satisfaction rates are similar, patients overall did favor having their surgeries in ambulatory centers when they had the choice or if they had experiences in both. And certainly having competition between ASCs and can lower costs as well. So what about the surgeon's perspective? Right now, the ASCs are used by 84% of spine surgeons, and 25% of all outpatient spine is done in the ASC. So it's certainly widely accepted, and certainly depends on the surgeon and obviously the environment and whether or not it's available to them, but that's across the board. And then in terms of efficiency, surgeons certainly see improvements in terms of scheduling, turnover, and start times. Dr. Zadablik presented an extremely efficient model. That is certainly, I would say, I don't think that, it's not an ambulatory center, but certainly the same type of model where they have strove to create an extremely efficient environment, and they have the ability to micromanage it without a bureaucracy. Anesthesia will have more motivation in the private environment oftentimes, especially when they go home after the cases are done. So people can get more cases done in the day and have more time for other ventures or to be with their family. In terms of quality, certainly you have great control over quality, and lots of studies have shown this at this point. In terms of different metrics such as safety and patient-centeredness and timeliness, the ASCs have performed at least at equal level, if not better, in terms of certain categories in terms of safety, timeliness, and cost efficiency in this particular study. But there are lots of other studies out there that show significant quality advantages in ASCs, or at least equivalency. It certainly can be done in a very safe way if we're careful. There are studies looking at outpatient surgeries, looking at seeing a reduction in post-op adverse events. In the hand and upper extremity world, they've seen a lower overall rate of adverse events in ambulatory centers. There's a significantly higher 7 and 30-day hospital readmission rates in the hospital-based departments versus ASCs for the similar types of procedures. And even ASCs can even have lower, and in this particular study had lower readmission rates for and hospital admission rates than even office-based surgery, which is the PO in this study. So for example, 7-day risk-adjusted readmissions were 0.8% versus 1.6% in the office setting. So So, I mean, it's been done in many different types of surgery that these studies have been performed looking at adverse events. And overall, most of them have shown that really there isn't a huge difference in complication rates in terms of knee replacement, unicompartmental knee replacements, and shoulder arthroplasty. There's really not a huge difference in complication rates at 90 days either. In terms of anesthesia, post-op complications, for example, malignant hyperthermia, they have actually shown that there's a lower rate than in the hospital for what it's worth, but certainly there's not an increased adverse event rate in anesthesia in that world. You know, in patients that are higher risk, lots of large databases have been used to look at quality and to look at perioperative complications, which have not found significant differences, even in high-risk populations. And using the NSQIP database, which is an excellent one for looking at complications, it's a very comprehensive database, and they've not found a higher complication rate. If not, they've found an improvement. And we also at my campus, I performed a study with Peter Passius, and we looked at ACDFs using two large national databases looking at length of stay and charges and complications, comparing inpatient versus outpatient, and certainly total charges was significantly lower for ACDFs in these databases, whereby there was a $10,000 savings between inpatient and outpatient stays. I'm sorry, inpatient versus outpatient surgery. And complications rates were significantly lower too. Now, certainly there's some bias in terms of reporting, but I think that it's reasonable to assume that the complication rates are at least similar, if not improved, in the outpatient surgical centers. So when controlling for comorbidities and age, we were still able to find that there was inpatient hospital ACDFs had a longer length of stay, they had increased charges, and they had increased complication rates compared to the ASC environment. Even though over the years since 2007, significant reimbursement has fallen for both ambulatory centers and for hospitals, there's still a significant gap in terms of the cost differences between them. And then there have been some large meta-analyses that have been published now showing that there's an equivalent safety profile between the two settings for ACDF surgery. And looking at ACDFs, which seems to be the focus of most of these studies, because ACDFs are thought to be one of the more dangerous procedures performed in the ASC environment. The meta-analyses have shown really no significant differences in terms of complications, whether they be larger or smaller complications such as dysphagia and pain and infection rates, for example. So NSQIP again showed that there were actually that in fact that there were lower odds of major morbidity with ACDFs and a lower odds of return to the OR within 30 days in patients that have been done in ASCs. And so this is actually a very good study that even though it's not a high level of evidence in terms of research protocols, but it certainly was very interesting looking at a groups with 1,000 consecutive cases that were performed at, doing ACDFs, 1,000 ACDFs performed in ambulatory center, and they found that there were no mortalities, the overall complication rates were comparable at least to the hospital environment. And actually what's important to note about this, which I didn't write in here, is really that these patients had a protocol where they were being observed for 4 to 6 hours. And it's been thought that that's very important, that that you have that protocol in place in order to catch patients that may have a hematoma and need to be transferred. So patients that have so basically mortality after ACDFs is similar as well in the ambulatory center versus a inpatient setting, which is one of the biggest fears that people really have in the ASC setting. Risk factors for complications tend to be the larger patients, so BMIs over 30, age over 65, having ASA classes of 3 or 4, dialysis patients, steroid use, recent sepsis, long operative times, and difficult airways. So really, we have to start thinking about what our case mix is going to be at ASCs. And for the most part, it is simpler cases, ACDFs and total disc replacements, one level for the most part, sometimes two levels in the appropriate patients. People are doing posterior cervical foraminotomies, lumbar decompressions, and MIS fusions like lumbar T-lifts and lateral lifts. Lateral lifts to a lesser extent. There is ample level 3 data and some level 4 data to support the safety and efficacy, as I said before. But the in general, people have accepted that these procedures are perceived as being safe. From a medical legal standpoint, I don't think you're going to be criticized for doing this level of case in an ambulatory setting. But that being said, regardless of the type of case and the intensity of the case, really you have to know yourself when you're deciding whether or not you're going to take a patient to the ASC environment. And I think that the most important thing is sort of to think about how you're going to get started if you're not already doing it. First of all, you really have to look at what your OR time is, your length of stay in your patients, how much blood you're losing, and your complication rates. So if you have a very stable, consistent outcome from a type of surgery, then that's the type of surgery that you really can evaluate and decide whether or not it's safe, and start comparing it and start thinking about whether or not you can do it in specific centers, because some centers are going to be more adept at handling larger procedures than others. For example, centers that focus in spinal surgeries, also some centers do have affiliates or adjacent rehab centers that can also be very helpful, and maybe a place that would be willing to take a slightly higher risk or a more intense level of care case. OR times over 2 hours really are probably inappropriate early on in ambulatory centers, even though some plastic surgeons and whatnot do cases routinely that are over 2 hours in that environment. You have to think about your morbidity, whether your patients are really up and walking around after the surgery or whether they take a long time to get started afterwards, what types of other associated procedures you're doing, such as iliac crest bone graft, for example, might be more painful and maybe might be more detrimental to that environment. So what type of approaches are you doing? Certainly, if you're doing MIS approaches, it can make a huge difference in terms of in multiple factors. First of all, in terms of pain control and perioperative morbidity. Also, you have to think about whether or not you're going to be able to give your patient 24 hours of antibiotic, which oftentimes you are not giving them 24 hours of the standard protocols for IV antibiotic post-op. And therefore, smaller wounds are less prone to infection. Shorter operative times are going to be less prone to infection. So certainly, you have to think about that, and also have appropriate post discharge protocols in order to adapt to these types of conditions. For example, with antibiotics, you may be giving patients oral antibiotics to go home with. Pain management, you may have a different pain management protocol, which I'm going to get into in a minute, which would then optimize the ability to send them home earlier. So you need to certainly know your team as well. This is a huge patient that we operated on and did an ambulatory outpatient procedure, but really it is important that every member of the team is on board with the type of surgery that you're performing. They should all be familiar with it so that things are efficient, and also they should have protocols in place that really make it easier to get through these procedures, such as anesthesia protocols that would reduce post-operative complications that would delay the patient's discharge. The facility is very important to understand and know as well. As I mentioned before, how often are they doing spine cases there? What types of equipment do they have? Do they have specialists that are adjacent or appropriate in the area that can help you if you do have a problem? All of these things are important. You need to know where it is geographically compared to the hospital that you are in relation to the hospital that you might send a patient to if there's an issue or a problem. And certainly you wouldn't want to do your first ASC spine case in a facility that doesn't normally do it. You really want to be in an environment where they're comfortable doing spine cases or larger cases, and make sure that they have all of the right equipment that you'll need, particularly things that you take for granted in the hospital and you might not use that often, but you have to make sure that they actually have it on hand. And then on top of that, you really have to start thinking about the types of patients that you have issues with when you do your surgeries in a hospital environment, and start stratifying them and appreciating what is appropriate and what will work out well in the ambulatory setting. Some of the bigger things that you don't think about normally in the hospital is what is the patient's social support if you're doing a middle range or smaller procedure. I don't really delve into a patient's home environment or what specific proximity they are to the hospital if I'm doing a hospital-based discectomy. But if I'm doing a procedure that's a smaller procedure in an ambulatory center, I'm always asking the patient how far they live. And particularly if I'm thinking about sending a patient home from the hospital or from an ambulatory center after an ACDF. So I want to be sure that they're going to have proximity to a hospital, that they have people that can observe them. I want to make sure that they know some of the thresholds to go into the emergency room. I'm also looking at red flags that are patient specific in terms of morbidity. The ones that I see most often that concern me in my environment are sleep apnea in large patients. That almost always is problematic, and even in the hospital environment, I'm always concerned about them. Patients that have high blood pressure, I've found that post-operative bleeding is much more common in ACDFs and patients that have difficult control of their blood pressure. But all of these factors on this list are very important. Their ASA class, of course, includes so many different factors. Older patients have difficulty recovering from anesthesia. If they've had anesthesia recently or before, it certainly helps to know that. And then also, what is their relationship to medications? Are they going to have be a problem in terms of controlling their pain levels post-op? Because it's very bad for you, it's bad for your center, it's bad for everybody if they have to bounce back to a hospital. Because their pain is not adequately controlled, because they really are, have high tolerances because of their usual usage. Psychiatric disease, I've had problems with psychiatric patients as well. I've even had patients that had a psychiatric problem sit beside somebody who had a legitimate complication, and they start mimicking that complication. So it's very important, obviously, to keep these things in mind. So what are our anesthetic goals? We really want to make sure that patients have adequate relaxation, and that they, the traditional goals of them not, their pain being controlled and not being conscious or having appropriate memory of, they should have anesthesia. But obviously we're also concerned about how they're going to recover from the anesthesia, and that's one of the more important differences. So we're very concerned about post-op nausea and vomiting, which can be make it very difficult to send them home. We want them to be coordinated and regain their sensorium and their judgment as quickly as possible, and return their bodily functions such as their bladder and their diet. As a surgeon, I think that counseling is one of the most important things. I want patients to understand and expect that they're going to go home and understand all of the different things that they can do to try and control symptoms or control complications. We talk about their diet, and since they're not going to have a lot of meals post-operatively, we discuss specifically what types of foods they should be eating after an ACDF, for example. We're much more concerned about drain placement, so I really try not to place a drain. It's rare that I place a drain in the ambulatory center. Sometimes I know some surgeons send patients home routinely after an ACDF with a drain, and I don't believe that that's the right thing to do. So I think that you really have to be careful and knowledgeable about how consistently you can avoid using a drain and what your blood loss levels are during those types of cases. So you certainly want to create an environment where you're as efficient as possible. Make sure that you have your team that knows your protocols and knows what you need, so that you can execute as quickly as possible and get the patient to wake up as quickly as possible for numerous reasons, obviously. We also, as I said before, we also have different protocols for supervision of patients as well. And I think it's very important that you know approximately how long your patients recover. For example, you may need to do your lumbar fusions first in the day so that they have time to get up and walk around. I like to do patients that need to be observed for 4 to 6 hours, my ACDFs, early in the day. So in terms of pain management, there are whole talks dedicated to how one should manage pain and what what targets we have with the different medications that we use and the different modalities, such as now intrasite steroids that are used after ACDF, all these different tricks that we can use to really help patients recover quicker, have less anesthesia, and therefore still have the same goals of having a seamless surgery, but have a quick recovery, and certainly a much more comfortable recovery. And it's well understood now that a multimodality approach, including multiple medications, is synergistic. I personally use 4 different medications in my patients, whether it's hospital-based or whether it's ambulatory, and I have them taking 2 of them automatically every day. They take an anti-inflammatory and a neuroleptic medication automatically before surgery and afterwards. And then I have them taking PRN medications for pain, such as a benzodiazepine or or a narcotic. People use muscle relaxers, all these different things that I'll go into in a second. Certainly, you need to take into account, adverse events, adverse effects. Different patients have issues that'll keep them from taking one particular agent versus another. But our goal is to try and get them on a large variety of medications and try to keep them off narcotics and use that as sort of the last medication that they take in their chain of medications. There are studies that have been done now looking at multimodality pain management. This is an excellent study everybody should look up with Devin and McGirt, which looked at different types of medications and their effect on the postoperative care. Certainly, I do a lot of extended release injections as well. That is helpful, and I don't do any type of anesthesia directed blocks. I do all blocks myself very aggressively in the muscle, and actually I think that it's very similar to what doctors are now doing when they're doing what's called awake fusions, whereby they're really trying to almost do all of their pain management during the procedure with injection. So there right now is fair evidence to suggest that preemptive analgesia reduces post-op pain. Anti-inflammatories are a very important component of post-operative pain management, and that the short-term use of NSAIDs really does not reduce fusion rates. And that's something that many of us were trained with the thought that we shouldn't be using anti-inflammatories, but we use it regularly now. I'm going to try and move things along a little bit quickly and get through this, but muscle relaxants are favored by some people. I don't use them personally in my practice. And so this is the list of medications that are commonly used in some of the protocols. I use Celebrex, I use pregabalin, acetaminophen is used as well on a regular basis by many people. And baclofen I do not use. I don't have a lot of experience with that, but I know many people who do, and they really appreciate it. Hydration is another thing that is important for you to consider. Patients pre-op and post-op need to have good hydration. It's part of their recovery for their mental status. We use 10 milligrams of IV dexamethasone as well in patients intraoperatively, as long as there are no contraindications, and we control their nausea with Zofran. So post-operative regimen is similar, as I said, and then we also use other obvious agents that most people do, such as stool softeners. The one thing I mentioned earlier that I think is really important to understand about the postoperative setting is that you should be using an IV antibiotic, while they're in the center, but then when they're discharged, we almost always give them a PO antibiotic. So in summary, I think that it's well established that ASC is safe for spine surgery. You just have to really take it slow when starting out. And hopefully I gave you some tips that'll help you with that. Feel free to reach out to me if you ever have any questions about it. I'm happy to help people if they have, if they have any specific issues. But certainly you have to remember that the same complication that occurs in a hospital can and will occur in an ASC. and that it is perceived differently when it's in an ASC environment. So as was said before, you really have to be careful and start out slow. Thank you very much.
Right, thank you, Michael. We're a little bit over time, and I'm going to go through my presentation very quickly to save a little bit of time for the Q&A. So without any further ado, so these are my disclosures. I have two surgery centers that I have a very small small interest in. Can you see? You can see my slides, I think, right? Yeah, okay. Those are the relevant disclosures for this talk. So I started doing spine surgery at ASC in about 2005, and I practiced at a single center for 10 years. It was overnight stay capable. I now practice at 3 centers because my practice situation changed and I have a little bit more geographic diversity. Spine surgery is being done nationwide. This article that just came out in Becker's is about shows 153 or more, and emphasis on the more because there are 4 centers in our area that were not on this list. And the considerations Mike has already gone over, I echo those thoughts. And I think that it's very important when you're doing cervical cases, especially, to pay attention to the no strikeout protocol that Rick Sasso from the CSRS is promulgated. He's the current president of the CSRS. All of these considerations are relevant: the physical plant, the equipment, and all of that. The surgeon is in potentially more control, as Dr. Gerling pointed out. That means that you can be more efficient and concentrate on the things that you believe as a surgeon are important to the care of your patients. So my experience in all outpatient spine cases over the last 10 years is roughly 1/3 to 2/3 outpatient versus inpatient. And in that time, 1/3 of the outpatient cases have been performed at the ASC. This is a distribution of all my outpatient cases. The vast majority are lumbar microdecompression. The rest are basically vertebral augmentations and interspinous process spacers. I've been a little bit slow to get involved with a lot of outpatient cervical surgery, which we'll discuss a little bit later. In those cases that were hospital, the majority of those were, again, lumbar microdecompressions, but almost all of the vertebral augmentations were done at the hospital setting, at least early on in this time, in this decade. And at the surgery center, I was very comfortable doing lumbar microdecompressions. I've done some miscellaneous cases like spinal cord stimulators, like those are appropriate for the outpatient setting in our environment. So here's the trend in the mix. As you can see, there's a little bit of surge in the hospital outpatient at the expense of the ASC inpatient or outpatient cases in the mid portion of this current decade, or this immediate past decade. But now the trend is starting to reverse and doing a little bit more in the surgery center for reasons that we'll discuss at the end. You can see that the first 5 years, this is the bottom part of the slide, basically 80% was done in the hospital setting as outpatient cases versus now it's about 50-50. So I've had no hospital transfers in this 10-year period, but there was a single patient transferred, usually for mental health admissions. We've only had one 90-day readmission that I'm aware of, a re-exploration at a local hospital for suspected CSF leak, and only one deep infection in my experience in a diabetic patient who developed an MRSA discitis. So the ACDFs and ACDs and TDRs were considered inpatient even in the hospital setting, so it kind of skews the numbers a little bit, even though many of these patients will go home the very next day. We do have overnight stay, so those patients are essentially identical, but they couldn't be tabulated the same way. The relative increase in hospital outpatient cases in the mid 2010s was probably due to the MIS SI joint fusions. The implant costs, insurance considerations, and Medicare restrictions were challenges in our environment, at least, for more complex lumbar procedures in Northern California. The supply and implant costs for vertebral augmentation have trended downwards and make these procedures more favorable for ASCs. Now, I want to say also as a disclaimer, my Northern California experience is unique and probably only partially correlates, if at all, with national trends. The ASCs have been more accessible during the COVID pandemic than our hospitals were. Our county actually had the first documented COVID death in the pandemic, and we were probably one of the first places in California to be hit hard. Others have unfortunately passed us since then, and we're a little bit better under control with recent surges. Future trends include an increased number of outpatient anterior cervical procedures as safety protocols become more standardized, an increase in MIS lumbar fusions in some centers throughout the country, including doing ALIF with MIS posterior fixation as in an ambulatory setting, and then bundles and episodes of care are coming into place where private insurance companies, generally with a conveyor, will work out a bundle that will include everything in the episode of the cost. It's actually slightly more favorable to the surgeon than the standard reimbursement protocols, but that's for the future, a little bit in the present. So I want to give credit to Dr. Sasso, Rick Sasso, who's the current president of the CSRS, for coming up with this no strikeout protocol. This has been a passion of his for some time. You can see the link there. The CSRS is our sister society. I would encourage everybody who does surgery in an ambulatory setting, and even if you don't, to download these educational materials and train your staff. And this is especially important if you're doing anterior cervical work in the outpatient setting. With that, I thank you very much, and we'll open it all to questions. I'll be able to go a little bit over time. So I don't see any questions coming up, but I have a question for Tom, if he's still on the line. Are you still there, Tom?
I am.
Yeah. So how were you able to sell this concept of building a specialty hospital to the university? I presume this was financed by your university. Is that correct?
Yeah, it's completely university owned and financed. And I went through 3 different CEOs before I finally got approval. So it wasn't an easy process. I just had to continue to push. I think as we got busier at the large hospital, they realized that the inefficiency in an orthopedic practice was costing money to the institution. You know, orthopedics is probably about 35% of the overall margin of the hospital. So when orthopedics is not working efficiently, everybody suffers. And that message finally got through. And on my 3rd try with the 3rd CEO, I found a willing partner, and he was really easy to work with. But it wasn't easy. I must say, it takes a lot of time and steady pressure.
Oh, that's fantastic. So Greg, are you doing anterior cervicals at your Rothman outpatient surgical centers, and how are you keeping them overnight? I mean, do you have your safety protocols in place, and how has been your group's results in terms of avoiding rehospitalization and catastrophic problems?
Sure. I mean, so yes, we are doing ACDFs at the specialty hospital. We don't do them at any of the ambulatory surgery centers. So we do have a Rothman orthopedic protocol, because there's, between New York and New Jersey and Pennsylvania, there's something like 20 spine surgeons now. Our protocol actually says everybody's supposed to stay overnight with the drain in, just for the simple fact that, we've probably, since I have been here, which is now starting my 7th year, had probably 4 or 5 total, postoperative hematomas in the anterior cervical spine. Fortunately, none of the epidural hematomas have died, but we have had, one of them that was a couple of years ago that was an outpatient ACDF that the patient ended up having significant issues, versus all of the other ones that have been inpatient that, we didn't have Dr. Sasso's specific program, but, it was somebody identified it, they had their neck swept, they got intubated and taken back to the OR, and, long term, they had no real issues. So when you have one that you have, major problems with versus everybody else that, oh, look, it happened, and, 2 weeks down the road, they're doing fine. We just don't wait. We keep everybody overnight.
So same question for you, Mike. Are you doing your cervicals at your outpatient center, and what are your protocols and what's been your experience with the hematomas and transfers and the like?
I've had I think I've had about 5 hematomas in the last 15 years. So, you know, I get them, and it's, so I think that it's really hard to completely avoid them. In all of those cases, the patients had no reason that I could identify at the time of surgery that they would, you know, that they would have a hematoma, except
I
one of.
totally agree on that point, Mike.
What's that?
I totally agree with you. The ones that we've had, no reason, zero reason,
Right.
no risk.
Yeah, and one of them, and I mean, even one of them had a drain in. It was in the hospital, and the main issue that we think happened was that the patient just had, you know, the blood pressure was lower during the surgery, but the blood pressure issue really just caused, it shot through the roof in the recovery room, and it started bleeding. And even with the drain in, it still, I needed to bring him back to the OR. You know, and studies have shown that the vast majority of hematomas occur in the first 4 hours after the surgery, and that's been my experience. That's happened, every one of them. It happened within the first 4 hours. We were aware of the fact that it was evolving because we kept them and observed them for that period of time. Two of them, it occurred in an ambulatory center, and we were aware. We re-intubated them and evacuated it and washed it out and put in a drain. And you know, really, once you get in there, I have yet to get in there to wash it out and see something that looked like it was the cause of the bleeding. It's strange. It's almost like the hematoma, the pressure puts it out before you can get in. But in all of those cases, even the ones that were in the ambulatory center, I mean, they require you to be really alert and on, you know, on the ball, bring them back in efficient manner. The first time it ever happened to me, the anesthesiologist actually didn't handle it very well when they re-intubated them, and that caused a complication with the pharynx because the pharynx was pushed to the side. But anyway, the bottom line is that, I mean, I think that if you're watching the patients for 4 to 6 hours, your hemostasis is very careful, and you don't have patients that have a huge comorbidity that would predispose them, I think it's safe.
Well, that's an excellent discussion. I am not seeing a lot of questions from the audience here. Katie, am I missing anything? I'm trying to scroll through the questions. Do we have anything? Katie, you're muted, I think. She doesn't want to talk.
Yeah, I'm here.
Yeah, so I don't see any questions. Am I misreading that? Are we okay there?
We have a few.
Okay, could you mind reading them? Because for some reason I'm not seeing them.
Sure, this one's for Greg. How does scheduling work when you book an ACDF, Jefferson versus specialty hospital versus ASC? Does the surgeon decide, or do you have a scheduler to help you direct that?
Sure, no, I have that discussion with the patient. So we don't do it at an ASC, so it's either specialty hospital or home, or the Jefferson University Hospital, or I have one community hospital I operate to it. And I tell them all, I say, listen, from a realistic standpoint, you know, I've never personally had to transfer anybody from an ACDF. I think that it's very safe. But I say, if there is a problem, if you have a problem at the specialty hospital, you will have to get transferred to Thomas Jefferson University Hospital. There's just no doubt about it. And I always tell them, I've never had to do it in the last 5 years, but it doesn't mean that you're not going to be the first. If that is something that really bothers you, then we should do it at the university hospital. If you don't mind that, you know, the parking is easier, the rooms are nicer, you get out faster, and I basically let the patient make that decision if they're a candidate, right? If they're somebody who comes in and has had 4 stents in the past, they don't get offered the specialty hospital. Only the people who are, you know, low risk, small surgery get even offered the specialty hospital.
Great. And then what's a good expected annual ROI percentage for an ASC?
You know, I mean, I don't think I can give you a specific number on that. I think that probably depends a lot on your location, how you're budgeting it, different things like that, what your mix is from, you know, an all spine ASC versus, you know, we are a big orthopedic practice. It has everything from pain management to spine surgery. So that's going to change a lot depending on what your mix of physicians is.
Yes, so I see the questions now, Katie. So I think Pierce Nunley is asking, Greg, how does scheduling work when you book an ACDF, Jefferson versus Specialty Hospital versus ASC? Does the surgeon decide, or do you have a scheduler help direct this?
Yeah, we asked that one.
Just got that.
That's what you already covered that one. All right. And then I think, another question. This is more for those in New York and New Jersey. What is your perspective as it pertains to the valuation of ASCs in New Jersey, considering the moratorium on ASC licensees in the state? I'm not sure that's an easy one to answer. Anyone want to tackle that?
Well, I mean, I operate in New York and New Jersey, and I occasionally do cases at those centers, but I'm no longer an owner. So I don't know the answer to that question. I think that there are a dime a dozen, and they're all really looking for surgeons to operate in their centers. And the bottom line is that it has to be valuable for you as a provider. For a couple of years, I actually made some dividends from being an owner, and I withdrew and no longer do, and I'm very happy not to. It wasn't worth the effort to have to go there if it didn't make sense for your practice. If it's efficient for you, then that's the right place to be, and I think that if it's the best thing for your patient and it's the best thing for your practice, then that's the way to go. But I can't answer that question better than that.
So great. I think we're going to wrap it up now. I do want to say that Katie is going to put the link to the CSRS patient safety protocol on the LSRS website. And this presentation will be available by video within the next week or so. I want to thank the faculty. They're all excellent presentations. I was honored to be able to moderate this session. And I thank all the attendees for taking a time out of their evening to attend. Thank you very much.
Thanks, Jeff.
Thanks, Jeff. Well
Thank
done.
you.